Dear audience, dear chair, I would like to present my 9 months progress on my PhD topic, which is the comparison of hormonal contraceptive methods and the route of administration. I'm Gábor Vleskó and I work as a specialist at the Department of Obstetrics and Gynecology. And my vision is to expand knowledge on contraception in the world so that every woman can avoid unwanted pregnancy. And the vision to reach this is to find new information that can help women to choose the best option for contraception. I have 2 ongoing projects. The first is about the parenteral and oral contraceptive methods, and the second one is about the role of obesity on hormonal contraceptives. So the first project is investigating the efficacy and safety of combined parenteral and oral contraceptives in reproductive age women. This is a systematic review and a meta-analysis. We know that there's almost 2 billion women of reproductive age and that over 150 million women use contraceptive pills as a method. We also know from studies that there are the compliance, the effectiveness of the contraceptive methods highly depends on the compliance with the regimen. And we also, some trials found that 1 in 2 women tended to miss 3 or even more pills per cycle. So our aim is to investigate the efficacy, the cycle control, the compliance, and the adverse events associated with the parenteral contraceptive methods. The clinical question was that are combined parenteral contraceptive methods as effective as oral contraceptives? We had the population of women of reproductive age. The intervention was the parenteral contraceptives, so the transdermal patch and the vaginal ring. And as comparison, we had the combined oral contraceptives. The primary outcome was the efficacy in Pearl index, and the secondary outcomes we had compliance, adverse events, cycle control. The hypothesis was that parenteral administration of the hormones is preferable to the oral route because it is more effective and associated with fewer side effects. We performed a systematic search on the 3 main databases at the end of November with the following search key, and we only searched for randomized control trials. We found over 3,400 searches, and in the end we had 13 eligible full texts. This was a primary outcome Pearl index, and the outcome measure is mean difference. The Pearl index is an index about efficacy. The lower number we have, below 1, that's said to be a good contraceptive method, and if a pair doesn't use any method, it's around 85. At this forest plot, we can see that we could not detect the difference in efficacy between the parenteral and the oral administration routes, which tells us that we can encourage women who have a fear of taking pills to use another way of administration of these hormones because it has the same efficacy. In terms of compliance, we can say that the parenteral methods goes with a better compliance, and we also performed a subgroup analysis, which said we could see that the patch had significantly better compliance, and there was also a significant difference between the subgroups. So if we want to find a method for women and want to avoid discontinuation, we would encourage a woman to use a transdermal patch, which is a new method, but we can tell them these. Of course, one of the mostly there are feared side effects of contraception, and one of these adverse events was breast discomfort, and we found an elevated odds ratio for adverse events like breast discomfort in this case, and we also found that in terms of patch, we found this mathematically significantly higher occurrence. So if patient had previous symptoms with the oral contraception, we wouldn't suggest to use a patch, although it's the same efficacy but might have worse side effects. Other two and compared side effects are nausea and vomiting. We found that there is no difference. We couldn't detect a difference between parenteral and oral, the oral administration ways, but there was a significant subgroup difference if we checked the transdermal patch and the ring. And we found that there's lower risk of nausea in the ring subgroup. In terms of vomiting, we also found that they are almost similar if we check the parenteral, but if we perform subgroup analysis, we found that there's a lower risk in the ring subgroup. Check the vaginal discharge in the vaginal ring, and we found that there's a mathematically significantly higher risk for developing discharge. So in these cases, if women have fear from an increased discharge, we wouldn't suggest the vaginal ring. The strength of our study is that we only included randomized control trials, and this is a comprehensive analysis of the different administration methods. We had limitations. We had only one direct ring versus patch comparison, and there's no uniform way to report either the compliance or the adverse events. The conclusion is that the contraceptive efficacy is similar regardless the way of administration. However, a personalized choice can be offered to patients based on the different side effect characteristics. The implication for practice is that we should try to tailor and personalize the contraceptive use, and we should look for a method which goes with a better compliance and less discontinuation. Implication for research is to try different drug types and also can try different administration ways or different patches, or not combined hormonal patches, but patches which only include one drug. And the progress is we are finished with the manuscript, and we are going to send it to internal review tomorrow. The journal selection is the British Journal of Obstetrics and Gynecology. The second project is investigating the role of obesity on hormonal contraceptives. We know that it is predicted that by the end of this decade, 1 in every 5 women will be living with obesity, and the increased body weight might change the metabolic processes, this way the contraceptive efficacy and also the adverse event incidence. Our aim is to investigate the efficacy and the side effect profile of contraceptive methods in overweight and obese women. The question is that are these contraceptive methods less effective in overweight women and in women with obesity? We had women of reproductive age, and even this BMI over 25 compared to normal BMI. The primary outcome would be pregnancy, and the secondary outcomes adverse events. The hypothesis is that hormonal contraceptive methods are less effective in overweight women due to the altered pharmacokinetics. We performed the preliminary search on the 3 main databases with the following search key. The second project stands like this, waiting for the Prospero registration to finish. And this is a summary of my 2 projects. The first is sent to internal review, and the second we plan to finish in August. And I would like to thank your attention with a quote from William Osler, that medicine is a science of uncertainty and the art of probability.
Thank you for your presentation. It was brilliant. And I would like to ask that, what do you think? Is it not dangerous to give contraceptives to obese patients?
Yes, that's what we are planning to map, but we are always afraid of this subject, and we try to avoid estrogens. But I think that this is might be an unnecessary fear, because what we always forget that getting pregnant or getting an unwanted pregnancy in a morbidly obese patients or patient with diabetes or other metabolic issues might even pose a higher risk than taking a pill or having a contraceptive, because this risk affects two living creatures, so the mother and the fetus too. So, and also if it's an unwanted pregnancy, an interruption might be a high risk with an obese patient, and also the pregnancy itself carries a high risk.
Thank you.
I have to stress to that you will inherit the problem of unwanted pregnancy, because at present in Hungary 25% of all pregnancies will end up as unwanted pregnancies in induced abortions. So the topic you mentioned and you are running around is of utmost importance. And as you have presented, compliance, ineffective compliance of patients is a reason for unwanted pregnancies. So we have to, and that will be a great program for generation. So my question is, speaking about personalization of conception, what is your recommendation for young generation between 25, middle-aged generation in the late reproductive ages, and over 40?
Well,
according to the data you have went through.
Yes. My personal view is that what I see is the younger the patient population is, they are the more open to new methods. So if I try to encourage somebody in the mid-30s to use a vaginal ring or a transdermal patch, they might have difficulties to accept this because they have a fear from this. So it's a lot easier to encourage younger women to find these new methods. And over 40, I think, and it also depends on the parenteral status, if they already had vaginal deliveries or not, because also the intrauterine devices are improving, and we are having such hormonal intrauterine devices that can be used also in nulliparies. But and over 40, this fear, which might be an unnecessary fear of thrombosis and other things, we use progesterone-only pills, or we use the progesterone-containing intrauterine devices.